Okay, so now that we're all here, let's get started the meeting. Okay, so good morning, good afternoon, and good evening, everybody. I'm Monica Yun Chu from Chang Memorial Hospital. As the moderator today, please allow me to introduce Dr. Rami Hallac and our two panelists, Dr. Shosha Lin and Professor Howard Chang. And Dr. Xiaoxiaoling is in charge the research center of our craniofacial department in Chang Memorial Hospital. And Dr. Howard Chang is also the professor of craniofacial trauma department in Chang Memorial Hospital. And now it's really my pleasure to introduce the star today, Professor Rami Hallac. And he just said that he feels better to call him Rami. So I'll call him Rami. Rami now works as an assistant professor in plastic surgery department of UT Southwestern Medical Center, and he's got PhD in radiological sciences. And he majored in medical imaging, 3D printing, and artificial intelligence that is applied on craniofacial field. So today, Rami is going to share his experience on artificial intelligence in the diagnosis and treatment of craniofacial anomaly. I personally can't wait to hear his talk. Let's welcome Rami. Hello,
hey,
Rami.
Hey,
Can you hear me? Yeah,
Yes.
we can hear you very well.
Well, thank you so
Yes.
much for the introduction, and thank you all for joining this talk. I really appreciate the invitation. Many thanks to Dr. Cho.
Thank you, Rami.
Can you see my screen?
Yeah, we can see it.
All right. So again, my name is Rami, and today I'll be talking to you. About artificial intelligence and craniofacial surgery. Artificial intelligence is a very important topic now and has been getting a lot of attention in the medical field. Today, I will go over some ideas of artificial intelligence and how we use these models in our lab to do studies on machine learning. So if you all look at these pictures, you can recognize many of them, right? And what your brain tries to do is you try to identify features in these images and try to associate them with names in your brain. So your brain has a dictionary of names and also features or information from these pictures that can associate each other. And your brain does that amazingly. But how can we make a computer do similar things? I mean, if you look at Elon Musk, and many of you might know him, you can recognize features in Elon Musk, and you can recognize that's him. But if Elon Musk is thinking so hard and giving us a facial expression, you can still recognize Elon Musk, even when he's giving us a goofy face, or when he's having a bad hair day. You can still recognize Elon Musk, even though he looks different in all these pictures. Now, if I give you pictures of patients that have craniofacial differences, and I ask you, what is different about these patients? What makes them look different? Your brain might recognize these differences, and you might be able to recognize what is going on. But if I ask you to describe for me this in either writing or a computer program, it becomes very difficult. The task goes from seemingly easy to very difficult. And why is that? Why we cannot articulate or write a program to describe these differences? And how can we make the computer much better? So that's where artificial intelligence becomes very important. And artificial intelligence is an evolution. Right now, I would say we are somewhere either in the beginning or middle of artificial intelligence. Artificial intelligence has been used in many areas in our daily life. I mean, if you look at your cell phone, you can now unlock your cell phone with just your face. You have so many features now on iPhone that if you take a picture of certain plant, artificial intelligence can detect what this plant is or what this animal is. So it has been gaining much interest, and it has been actually being used in our daily life. But in plastic and craniofacial surgery, even like in medicine or healthcare generally, artificial intelligence is still lacking, especially in specialized medicine such as craniofacial surgery. But why is that? And one of the reasons might be is lack of data. This recent paper published in PRS Global Open, they tried to do a retrospective study or a review on artificial intelligence in plastic surgery. And they only found 89 novel articles in machine learning and artificial intelligence. And for them, there were only 14 satisfied articles after looking into the inclusion and exclusion criteria they put. So again, artificial intelligence is still lacking in the area of plastic surgery. But we all do a lot of imaging for our craniofacial patients. We use 2D photography, we use 3D photography, and we also use 4D imaging sometimes. But every institution, because it's a specialized medicine, we still don't have enough data. And for us to be able to push the frontiers in artificial intelligence and plastic surgery, we might need to do some collaboration. But we need to remember that photographs are PHI. And in order for us to find a way to collaborate, we need to find a way to identify data. I mean, what the main thing craniofacial surgeons try to do is try to take a patient with craniofacial difference and try to make them look normal or like normal. But what does that mean? What does normal mean? Normal is something different among surgeons, and it can be interpreted differently. And for some surgeons, normal can be something very subjective. And for example, in this picture, I'm not sure how many of you noticed that this patient had an ear deformity, and that's why the surgery was done. Our brain is always looking to find clues from the face, because that's how we are trained to look at people. We use our face as the window to the world, and that's where we get most of our features. And I'm not sure how many noticed the deformity on the ear. But even when we try to look at normality, it can be subjective. It can be different from one person to another. And this can depend on our experience, and some two surgeons might have totally different outcomes. So one issue that was brought to me is different surgical techniques in sagittal craniosynostosis. So in the United States, we treat patients with craniosynostosis at early age. And there are many techniques that has been developed to treat these patients. But until today, we don't know specifically how every surgical technique provide an outcome. So we collaborated with 3 institutions, and we gathered hundreds of data to try to see how each technique provides different surgical outcomes. And something like a surgical technique is still not understood very well. And there's a lot of research can be done in plastic surgery to figure out how to, which surgical technique is better, and how to make like deformities such as sagittal craniosynostosis look more normal. There are many different ways we can do that. But one way definitely is artificial intelligence or machine learning. And this has been, again, gaining so much interest in the healthcare. And today I want to be focusing more on machine learning as our way to analyze data in our center. So artificial intelligence is a very broad concept. And underneath it, you can see there are 2 concepts. There is a machine learning, which you can think of as clustering, as an example. But there's also deep learning. And deep learning is something like a convolutional neural network, like CNN. And today I'm going to be focusing on these 2, giving you an overview of what each one does and how we use them in our lab to look at craniofacial differences and also ear deformity. So I'm going to go with a simple overview on how these machine learning models can be thought of as a piece of math. The most important thing in machine learning is something called feature extraction. So if you look at this graph here, this is how you train a computer. So first you need an input, which can be either an image, or it can be a speech, or it can be just data. In craniofacial surgery, we tend to work a lot with images. So our input is often an image. But once you put an input in, you have to extract features. Just like our brain did with the celebrities, we try to find features of them to figure out who they are. And once we do that, we have to classify these features into ways that we then label them as an outcome. So for example, if we put a car into our model, we have to extract features of a car and then classify it to make sure it's a car, not an animal, and then label it as a car. And feature extraction is something very important for our models to be successful. Because if you look at features that are not important for that particular disease, then our models will not be able to identify the images very clearly or very, very accurately. So in order to do that, I'm going to do an example using the alphabets because we are all familiar with them. And I want to show you how these alphabets can be used as how can we extract features from these alphabets. And I'm going to focus on 3 alphabets today. I'm going to focus on the letters I, P, and R. This is a very simple way to extract these features. This is not how a computer will do it, or this is not the right way to train a computer. It's just a simple example to help you understand what features mean. So if we look at the letter I, for example, we can describe an eye as just a line, right? So if we look at an eye, we can see a line and we say, this is an eye. But if we look at the letter P, then we can probably find 2 features. We can find a straight line, just like the letter I. But then if we add the semicircle, it becomes a P. And this is how our brain probably interprets this letter. And if we look at the letter R, it has 3 features. It has the letter I, but then it can be the letter P if you add the semicircle. But then if we add another feature to it, it becomes the letter I. So when we extract features from these letters, we can try to find labeling to them to see, okay, this is an I or an R or a P. Feature extraction, again, is very important, but that's not the only way. We can do feature extraction manually, like by writing a program, just how I showed you, and say, if you find these 3 features, then define which one is I or R or P. But also feature extraction can be done automatically by a computer. Sometimes we don't have to tell the computer what features to look at. The computer can extract features on its own. So there are 2 ways. Either we do it by writing a program or the computer extracting its features. But there's another important part of the machine learning model, which is classification. And classification is done based on machine learning models. And today I'm going to be showing you a few machine learning models, and I'm going to be focusing on 3 of them. I'm going to be focusing on support vector machines, Kmeans, clustering, and neural networks. And the reason I'm going to be talking about these is because I've used those in my studies, and it will be important to understand the basic idea of them so you'll understand why I use them in my studies. But if you look at the machine learning models, there's 2 major components. There's something called supervised, and there's something called unsupervised. And under supervised, there are some models, versus unsupervised, there's different models or similar models. So what is the difference between supervised machine learning and unsupervised? In supervised, the computer is telling you, I need to know if this photo, for example, is a cat or a dog. So you have to do the labeling for me. You have to tell me what is normal, what's abnormal. You need to tell me if it's a cat or a dog. Versus unsupervised, the computer tells you, you don't need to tell me what is a cat or what's a dog. Just give me the features, And I can classify these data based on the information you give me. So if you don't know if it's normal or abnormal, you don't have to tell me. I can figure it out by myself. So that's kind of the idea. What's the difference between supervised and unsupervised? And like the models that you can see under each supervised or unsupervised one. So the first one I want to talk to you is K-means clustering. And K-means clustering, it tries to cluster data based on features you give the computer. So for example, it goes through iteration, and it will try to find something called the centroid of each group. And it will try to separate these data based on the centroids. The only thing you have to tell the computer is how many groups you want the computer to separate. So for example, if we are looking at, let's say, 3 surgical techniques, and your features are recovery time and length of surgery, then you can tell the data, well, you can tell the computer, well, my features are recovery time and length of surgery. And I have 3 surgeries. So try to separate this data or classify them into 3 groups. So what the computer tries to do is to try to find these centroids in every group and try to separate the data into 3 techniques based on these 2 features that you give the computer. The way it does it is through iteration until it gets the best clustering. Now, support vector machine is kind of similar idea, but instead of separating them into cluster, it tries to divide the data or separate the data by something called the hyperplane. And it tries to find where your data is and tries to draw this imaginary line to separate your groups. If you can notice, these 2 ideas are similar, K-means clustering and support vector machine. But they're a little bit different, and they are different, again, in that support vector machine falls under supervised machine learning model, versus as K-means clustering, it falls under unsupervised. So in other words, if you want to use support vector machine, you have to tell the computer, you have to label the data for the computer. But for K-means clustering, you don't have to do that. Another important thing I want to discuss is convolutional neural network. And honestly, this is one of the exciting things that's now happening in machine learning. And it works just like our human brain. The reason that it is very popular and it can augment our thinking, and it's a way it can offload some of our thoughts and imagination into a computer, because it is designed like a computer. It has nodes or neurons, and also it has multiple layers in it that mimics how the brain functions. So the first thing we see, like when we look at an image, we try to scan the image by pieces, extract features, and then try from these features to find what is this image trying to tell us. And that's how CNN or convolutional neural network works. So if I were to take these 3 letters, for example, again, the letters, the letters I, the letter L, and R, I'm sorry, the letters I, P, and R. And then we have these features that I told you about, like the 3 features we discussed. Then if you found all these features, you can tell the computer, okay, go through iterations and try to tell me which one is this letter. So if it only has 1 feature, then just go find an R. But if you find 2 features, then it's a P, and so on. And if you can look at these nodes, for example, the more you have, the more data you have, the more connectivity you have. And what CNN does that is very amazing is, and with the computers becoming so powerful, we don't have to write these equations ourselves. The computer does it automatically. And with computers becoming so powerful, we are able to do more things with the computers, try to classify more things and train the computer with more things. And one of the things that our brain try to do, like when we learn or when with our experience, is we try to see as much data as we can. We try to see as much patience as we can. And then from this, we can learn experience. And from this experience, we become better. But the nice thing about the computer is that the computer doesn't have to learn from one experience. We can bring all our experiences, all our photos, all our outcomes, and we can train the computer with it. So in that way, it's not only biased by a certain surgical technique or certain train of thought. It can be trained with so much data and experience. So I hope this is a very this introduction helped you understand a little bit about these techniques, because right now I'm gonna be talking more about how we use these models and these feature extraction in our studies. So the first one I want to talk about is machine learning in metopic craniosynostosis. And metopic craniosynostosis is a very controversial topic, at least here in the States, because as you know, to begin with, metopic craniosynostosis is a premature fusion of the metopic suture. And it is controversial because it goes from like over a spectrum. It can be a benign metopic ridge that in the States we don't do operation on it, but it can also be a severe metopic craniosynostosis that it leads to operation. And you can see here that you know, if it is benign, then the patient just don't need to do anything, just to observe your patient. But if this spectrum has a gray area where some patients fall in between benign metopic ridge and metopic craniosynostosis, it becomes a very difficult task to differentiate which one needs a surgery and which one doesn't. And accurate differentiation between them becomes very important. The way they do that, we do that usually clinically, is usually by doing a CT scan, physical exam, and also looking at you know, some other factors or like in the clinical exam. The literature shows that this incidence of metopic craniosynostosis used to be around 3 to 4% of all craniosynostosis, but now it has jumped to something about 23% or 28%. There are many reasons for why this happened, and the literature describes, and one of them is demographic change or high paternal age. But other people speculate that there is a misdiagnosis of metopic ridge as metopic craniosynostosis. Actually, there's literature shows that if you have a patient in the gray area, where it is between benign metopic ridge and metopic craniosynostosis, and if you ask, let's say, 100 physicians to examine that particular patient, 50% of them will tell you this is metopic craniosynostosis and requires a surgery, and the other 50 will tell you this is benign metopic ridge and doesn't require surgery. And that's where the term probably you need a second opinion comes from. But there's another dilemma in metopic craniosynostosis. Do you need a CT scan or not? This paper published in 2007 in PRS suggested that you sometimes don't need a CT scan to detect metopic craniosynostosis. It says that craniofacial surgeons with different levels of experience can accurately diagnose single suture by physical exam alone. And the reason they're trying to emphasize on that, because CT scans is harmful to the babies. It has radiation dose, and you don't want to expose your patients to this radiation dose. So if you can diagnose them without a CT scan, that will be helpful. But other studies shows otherwise. So this paper in 2014 in Journal of Craniofacial Surgery, they had a case study where this patient had an elevated bony ridge, which looked like a metopic craniosynostosis. But when they did the CT scan, they realized that the patient didn't have a metopic craniosynostosis. The suture was not fused. And by that, they decided that, you know, using a CT scan, although it has a radiation dose, it is still lower risk than letting a patient go through a surgery that is not needed. So the question comes, do we need a CT scan or not? What if we can use machine learning to help us identify these patients without using a CT scan? So in here, I did a simulation. I took a normal patient and I took a patient with severe metopic craniosynostosis, and I did a simulation where I changed, where I deformed this 3D model to look like a metopic craniosynostosis. And what we did is we used an eye tracking study, and we asked lay people who don't know anything about like don't know much about craniosynostosis to tell us where they start noticing abnormality. And these volunteers in our study, they start noticing abnormalities at 80% to 90% of the deformed head shape. And when I asked the surgeons, can you please draw a line of where the threshold is of benign metopic ridge and metopic craniosynostosis, it was very controversial because it is hard to agree upon. But then we need to find a way to like train the computer to identify metopic ridge and metopic craniosynostosis. So this was my approach. So I tried to do a study that I would only ask the machine, regardless of how the physicians thought of the patient, on whether this is metopic ridge or metopic craniosynostosis. And the way I did that is I used a CT scan. And I took three different groups: normal, metopic ridge, and metopic craniosynostosis from our database, and I created a 3D model. But now you remember, I need a feature to train the computer with. For that feature, I used curvature analysis, and the reason I used this feature is because this is one of the main features in metopic craniosynostosis. You usually have this ridging on the forehead, which can show convexity, but also they have retrusion in the on the orbital rims, and this is retrusion. So if I did the curvature analysis, which is pretty much tell me the convexity and concavity on these 3D models, then I can have very valuable features. So for example, if you look at the ridging here for the normal, you don't see much redness because curvature doesn't tell me that this area is convex in these normal patients. But if you look at the metopic ridge, you can see a little bit of red values, which means that these metopic ridge patients have some ridging, but not as much as what you see on the metopic craniosynostosis. You see it to be very dark red. And the two important features or two important regions in the metopic craniosynostosis, again, is the midline of the forehead, but also the supraorbital rims. So if I take these values of curvature, the curvature values, and I plotted the lateral orbit and the mid forehead, then you get like the curvature values from the lateral orbit and mid forehead, then you can see that the data started to cause clustering. So these are four surgeons that we had in our department that they operated on different patients. And every graph shows their patients, the ones that they operated on versus the one they didn't operate on. And you can see here that this feature that I chose, which is curvature analysis, does separate the data into benign metopic ridge and metopic craniosynostosis. So what did I do? I used K-means clustering. Why I used K-means clustering? Because again, it is an unsupervised machine learning. I don't have to tell the computer what is normal, what's metopic ridge, and what's metopic craniosynostosis. It just tries through iteration to separate the data by itself. No CT scan, no problem. We did the same thing on our 3D photographs, and these circles that are not highlighted, just like an open circle, these data are from 3D photography, and you can see that the computer was still, or this feature was still very important, and they are still meaningful, just as what we did from the bone CT scan. So when I looked at the overall machine learning model, the computer was able to nicely separate the metopic ridge from the metopic craniosynostosis when, and we compared that with what the physicians did. So for example, if you see a circle within a circle, that means my computer or my machine learning model agreed with the surgeon. So the surgeon didn't operate on that kid, and my program says, that's correct, this patient is metopic ridge. But if you see a diamond within a diamond, that means the computer and the surgeon agreed that this kid is metopic craniosynostosis. And the model reached 93% agreement with the surgeons. So we had a very high agreement. But if you notice here, there are two cases where the computer and the machine learning model disagreed. In one instance, that the surgeon operated on the kid, but my program says that this kid is normal. It does not need an operation. So what did I do? I took that patient with all its clinical notes, and I gave it to the 4 surgeons we have. And I've asked them, would you operate on this kid? And what happened is 2 of the surgeons said, yes, I will do an operation. And 2 surgeons said, no, I will not do an operation. So in this case, what do you do, right? So that's where maybe a machine learning model can help the surgeon to either support or ask for another opinion. And this actual case happened. So for example, we had a case, this is a case study, where a kid came to our clinic and the surgeon was not sure if this patient falls between metopic craniosynostosis or metopic ridge. And he asked me to run this case, and this is a 3D photograph this is from a CT scan on our using a machine learning model. And independently, we came to the same conclusion. My model said where this yellow star is that he falls within the metopic ridge, and the surgeon independently saw the same. The surgeon thought that this kid is metopic ridge and does not need an operation. So you can see here that there's an agreement. But we are dealing with 2D, with 3D images, right? Even like 3D photography. And although this can eliminate radiation, but many patients don't have access to 3D images. And also what I've done so far is only based on metopic craniosynostosis. What about all other craniosynostosis like sagittal or unicoronal? So we decided to do a study using machine learning for an iPhone app or like a smartphone app, where a parent will just take a picture of their kid, and the computer will tell them if they need to be worried about having one of the craniosynostosis. And why we needed to do that. And one of the motivation is that some of the parents that they come to see our clinic, they usually have to drive 2 or 3 hours to see a specialized surgeon. And sometimes this can be very demanding. And what if they have a machine learning model that can tell them, well, yes, your drive is worthwhile. You need to go see a physician. So what we try to do is we try to take as much data as we can, and we use 2 models. We used the support vector machine, and we also used a neural network to try to work on the study, to try to separate data from normal metopic craniosynostosis, metopic craniosynostosis, sagittal craniosynostosis, and unicoronal. So we went to our database, all our images, all 2D images that we have that have consents. And if you look at the data, or the data number, or the number of patients, it's not very impressive. We only had 11 patients to train the system for metopic, and we only had 3 to test. And if you look at normal data, we only had 1 patient photo and 0 to test. So you can see the numbers are very low. And in order to train a computer, you need hundreds of data. The way we went about solving this problem is we went to the internet. We wrote a program that can identify certain phrases like metopic or sagittal or unicoronal from the internet. And we downloaded all the pictures of kids who have metopic craniosynostosis or sagittal or unicoronal. And then we asked the physicians to look at these photos to vet them that they are actually metopic, sagittal, or unicoronal. So now with doing that, by going to the internet and downloading all the images available, we went from having 0 normal images to test to 120. So now you see like how we enhanced our number of images to do our machine learning. So in order to do that, because some of the synostosis, you cannot identify them from the front of the face only, you have to look at the top of the head. We decided to train our model into 2 ways. We wrote a machine learning model to detect the front of the images and the top. And then based on that, we used it to classify the data to see if it's normal or craniosynostosis. And we used these features. So the first feature we used is the average gradient, which is kind of similar to curvature to identify metopic. We use cranial index to look at the sagittal patients, and we use the nose angle, as you can see here, to look at the unicoronal. So these are the features we decided to extract to look at our data. But we've also tried to write a program to actually segment the head shape on its own. And then we trained our CNN model for the front images and the top images. We actually did CNN model and again, SVM. And these are our results. If you look at the SVM, we had 91% accuracy of identifying true craniosynostosis versus normal. The CNN had only 90% accuracy. Although we expected the CNN to be better at identifying these diseases, the only issue is we didn't have enough data. So that's why SVM did better accuracy in this case than CNN. So with that, we were able to develop an iPhone app that you can simply take a picture of a patient, and with about 90% accuracy, it can tell you if the patient has hematopic, sagittal, or unicoronal, or he's normal. And this is not a diagnostic tool. Again, this is just a tool that can help parents to seek help to come to our hospital or to make the 4-hour drive to come see a physician. The other study I want to talk to you about is ear deformity. So ear deformity is another interesting issue because ear deformity comes with all shapes and forms. You can have lidding, or you can have a cup ear. You can have a cryptotia, a helicoram, a prominent ear. And if I were to write a program using modeling to describe the ear, it's very difficult. The ear, if you look at the ear, it has a lot of structures. And there's no way for me I can extract features from the ear by myself. The ear is very, very, very complicated. So I relied on the computer to extract the features by itself. So in this study, I did not extract features for the ear. I told the computer to extract features by itself. And the reason I wanted to do a study on ear deformity is because in our hospital, we treat patients with ear deformity non-surgically and using ear molding. And the only time this is very successful is when the patients are less than a month old. So the patients have to come to our clinic when they're only a few weeks old. And if they miss that window, then the ear becomes stiffened and we cannot do ear molding on it. And some parents or some even pediatricians are not very keen to identify ear abnormality. There was a study in the American Journal of Cosmetic Surgery where they had residents from 3 different departments, including plastic surgery, look at ear deformity. And on average, from all these departments, there was only 34% success rate in identifying ear deformity. So even trained physicians in plastic surgery and pediatrics are not very keen to identify ear abnormalities. There was only 34% success. And if the physicians who are, like, let's say the pediatricians are not keen in identifying these abnormalities, then the kids will miss their window to get non-invasive surgery. And in the future, they will have to do a surgery on their ear if they want it to be fixed. And there are many molding or ear molding techniques that can do correct the ear. And one of them is ear weld. For us, we don't use that. We use other techniques that I will show you later. But if you look at these ears and I've asked you, do these ears look normal after molding? I'm very sure we will get different results. Some of you might say, yes, it looks normal. And some of you might say, well, I can improve it. It's not that great. Because we are all subjective, right? But we can write a machine learning program that can objectively tell us which ear is normal or not. So for example, these 3 ears are from our center after post-treatment. And I asked the physician assistants to rate these ears for me. The physician assistants are the one who do the ear molding for us. And they had quite disagreement. So I've asked them to rate the ears from 1 to 5. And on all these images, our physician assistants disagree. Some of them, they gave it 4, but some of them, they gave it 1 or 2. So that led me to train a computer to decide whether these ears are normal or abnormal. So I took 457 ears that are deformed and 214 ears that are normal. And I split the data into 80% to train the computer and 20% to test it. I used the GoogleNet CNN, and GoogleNet is a pre-trained model that Google trained it for many, many images that they have. I think it's more than a million images. And I used that because the model is very well trained. And what I did is I did transfer learning, something called transfer learning, where I tweaked that model just instead of categorizing or classifying different photographs like cats or dogs or whatever to like ear deformity. And I told the computer to extract the features on its own. And this is how the model extracted its features. So if you look at the beginning, the first image, you can see like the outer line of the ear. But as you go deeper into the model, you can see that the computer is extracting things that I cannot understand. I don't know what the computer is exactly looking at. But the computer is doing its own job to extract these features. And when I tested the model, I got 94% accuracy. So the computer was able to identify 94% of the ear deformities on its own and tell me if it's normal or abnormal. And this is much better than the 34% the resident accuracy had. So the computer actually in here did a much better job than us. But again, I don't only want to detect ear abnormality. I want to know, like, after we do therapy on these ears, do these ears look normal or not? And there are different ways to do it. And again, I mentioned Earwell. In our center, we don't use Earwell. We use custom designed dental clay. So we shape these dental clays to a way that can match the other ear. And then we use adhesives with tape to put these dental clays on the ear to reshape the ear. And then we put like tape and adhesives to keep it in place. The patients come back every other week to check on their ear and to readjust the dental clay, and we keep it for about a month. These are all our patients we treated. This is in percentage. So we had 47% lidding, 18% helical kinks, and prominent ear, and so on. And this is our outcome. So this is an outcome that our physician assistants, when they rated the images, they agreed on. So the one on the left, all the physicians gave it a 3, which is pretty good or okay. And the one on the right, the physician's assistant gave the ear a 5. So they all agree that this is a great outcome. But if you look at the overall data between the 3 different PAs, you can see that they actually didn't agree that much. So if you look at the total score down there, the ones that gave it 4 and 5 scores, that is normal. The PA1 thought that 87% of the ears are normal, or like they corrected. PA2 thought it's 75%, and PA3 thought they're only 64%. So there's quite a range of, like, the patients, the PAs thinking that this is our ear molding was successful or not. But if you take the average of all the 3 PAs, it's about 75% of our ears were corrected. But how about the machine learning? Well, the machine learning did the exactly same thing. The machine learning told me that 75% of our ears were corrected, just like what the PAs did. But if you remember, I showed you what features the machine extracted. I couldn't understand it. I didn't know what the computer is looking for. But nowadays, with so much advancement in machine learning models, we can actually see what the computer is looking at. So these heat maps that you can see here on the right, it's something that the computer generated. And the computer is telling us what it's thinking it's abnormal. So you can see on the top one, it thinks that it's that fold is not looking right, versus on the lower one, it says that also the helical rim is incorrect. And that's why the machine flagged these 2 ears as abnormal. And when I use these heat maps that the computer generated to see where our ear molding technique is failing, it turned out that most of our failure comes on the helix of the ear. So 19 patients had ear deformity or not perfect correction on the helix versus anti-helix fold. But if you look at the bottom of it, for example, like number 3 here, it says it's outside the ear. So in that case, the machine was inaccurate to finding the features of the ear. It thought somewhere outside the ear is abnormal. So these show you that the machine learning model can still be improved to make it much more efficient. So on the next slide, I want to show you how our machine learning model works for the ear. So this picture is from the internet, and this baby had an ear deformity, as you can see, and he was corrected using ear molding. And I want to use my machine learning model to take a picture of these ears, and I want the machine to tell me if they're correct or not. So this is an example of how the machine learning model works. So here I turn on my camera, and now I'm going to take a picture of the ear. And I snap the picture, and then now the machine learning model works, and it's telling me it's deformity. And it's showing me where it's thinking is deformed. And now I'm going to the one that's corrected. I'm taking a picture, and now it's telling me this ear is normal, that it's correcting, it's perfect. So here you can see that within seconds, the machine was able to identify ear deformity. And this is like in real time. The machine learning models are fast, they're efficient, and they can look at much more images that we can ever look at, and they can learn much more faster than us. I want to just leave you with one thing. Next time you get the computer to ask you to prove that you are not a robot. This is the biggest joke on human mankind. Robots are taking over. And with that, I'll leave it. That's everything I have for you today. I hope you enjoyed it. Thank you so much.
Thank you, Rami. Okay, it seems there's questions from the audience, but I think I firstly invite our panelists for giving some comments. So we start from Professor Shosha Lin. Professor Lin, can you hear us? Professor Lin, you're mute. Oh, okay. Okay, thank you. Would you please give us some comments?
Yeah. Thank you, Dr. Rami. This is a great talking. Although we can learn more AI application in the classification of craniofacial anomalies. Actually, we currently have some projects that are using machine learning or AI technique in our center. I believe that was useful and helpful information for us in the future study. Thank you.
Thank you so much.
May I ask some question now?
Sure, please.
Okay, I have some question. One question is I am curious. How do you come up with the idea of using curvature as a feature value?
Yeah, so again, I'm not a craniofacial surgeon, right? So when the physicians came to me and asked me to like identify where the threshold is between metopic craniosynostosis and metopic ridge, one thing they kept mentioning is the ridging. And for me, like the way to measure it was, or at least in my opinion, the way I was able to learn about it is by looking at if it's curved or not, if it has a lot of bulging on the forehead. And since curvature analysis will tell us if something is curved or not, I was told this can be a very important feature to detect metopic craniosynostosis. I felt like it's kind of like, if you use cranial index, it is for sagittal craniosynostosis. For me, it felt like curvature is a very important feature for metopic.
Okay, I guess I will try to use this curvature feature applied in our study. And the second question is, if we have a little population or no more population, because how do you reduce overfitting if you did not use data augmentation, such as in a Craniofacial notice shape? You have because if you use the data augmentation technique such as the rescale and the translation technique, if you don't use this data augmentation, how do you overcome the overfitting problem?
We did use data augmentation. So we did some sort of translation and rotation on the data before we train it. So we did do a lot of data augmentation.
For overall study, you always do this as kind of data augmentation.
Yes.
Okay.
We do data augmentation, and we also do cross-validation. Okay. So our models, usually we run our models 5 times, like we do 5-fold cross-validation to make sure that the data is not biased to one sort of training.
And how many times for this data augmentation?
We do the data augmentation once, maybe like one for every image or selected ones. But when we run the machine learning models, we also do 5-fold cross-validation to make sure that we don't run the machine learning model once. We train and test the model more than once to make sure that we didn't get our results by accident or by luck.
And one question is, you use a different pre-trained model in different application. How do you choose and assure this pre-trained model is appropriate for your study?
Yeah, that's a good question. So usually it's a trial and error. So for the ears, for example, before we used GoogleNet, we used AlexNet.
Yeah.
But AlexNet didn't give us good results as GoogleNet. So it's pretty much trial and error. So we tried AlexNet, it didn't work. So we ended up using GoogleNet. But for the craniosynostosis one, we tried to use a model that was trained for the faces. There's a pre-trained model only for faces, and we use that because we thought it will give us better results.
Okay, I understand. Thank you. Actually, we have some AI study. So later, if I have any question, may I ask you anytime?
Of course, just ask Dr. Cho. He has my email address. You're always welcome, and I'm happy also to collaborate with any one of you. We're always open to collaboration.
Thank you.
Yeah, you're welcome. Thank you so much.
Thank you so much.
Thank you so much for Professor Ling's questions and comments. And now I would like to invite Professor Howard Chang. Professor Howard Chang, can you hear us?
Yes. Thank you, Dr. Rami. Very nice talk. I think AI has become more and more popular now, although still have a lot of limitations, especially for surgical applications. But I think as a craniofacial surgeon, we do need to, although we don't need to understand the detail of the AI technology, but I think it's very important for us to understand the core technology and the architectures and the knowledge still we need to know on how we to evaluate the performance and the value of AI. So actually, I also have one question here. Because you are talking about the accuracy of the machine learning. So I think the clinical accuracy of the AI for craniofacial applications must be tested using a lot of images source before the AI can play a role in the diagnosis. So to achieve this purpose, the standardization of the imaging, I think is very, very important. So my question is that how can you standardize all these craniofacial images before they can be used for the machine learning? Thank you.
I don't think the images need to be standardized, right? So if you train the computer with more images that are not standardized, then the computer will be able to understand that the images are not standardized and be trained on multiple views. And this is actually the limitation we have, because all our images we have from our clinic are standardized. So when we go to the public and everybody starts taking different images that are not the same way we take them in our hospital, then that's where the accuracy of the machine learning gets affected. So I think, in my opinion, we should be training the models with images that are not standardized, so that when we put it in practice, the machine models will be trained on more diverse data.
Mm-hmm. Okay.
So that's why I was thinking that if we can collaborate, because probably like images that are obtained from other institutions are different. They're from different cameras. They have different like lighting system, and if we can take all this data, train the computer will be able to understand and differentiate what we want exactly to extract from the images.
Okay, thank you.
Thank you, Professor Chan. And now, can we invite Professor Lunzhou Lo? Can we invite Professor Lo to give us some comments or some questions? Professor Lo?
Hi, Rami. Yes.
Hey, Dr. Lo.
We should say hello to you and listen to your talk I'm sorry. I actually do not have question for you, and we do hope in our department we could develop this AI application in our daily clinical works. So thank you for your talk, and hopefully in the future we can do something together in this field. And also please say hello to Alex and all the other colleagues. Thank you.
I will. Thank you so much.
Thank you, Professor Lo. And there's a question from Dr. Ting-Shan Lu, and she asked about in the AI training of craniosynostosis, it seems you don't need the normal cases. This normal shape of the head has the role in the AI learning. And what kinds of craniosynostosis do you find most difficult for the AI training? Do you need lateral view photo for the sagittal? Thank you.
Yeah, I mean, we don't. The only reason we use normal data.
Recording in progress.
I think if I understand the question is why we use normal to identify craniosynostosis. The reason we use normal is because if the patient doesn't have any sort of craniosynostosis, it has to be labeled as normal. So we kind of need to understand what normal is, so that otherwise, if we only train the computer with craniosynostosis and then a normal patient take a picture, then it will have to be one of the craniosynostosis. It cannot be labeled as normal. And I think the most difficult one for craniosynostosis was probably the unilateral, just because we don't have much data. And also it can be like unilateral or bilateral. And of course, more images we have, especially with lateral view, top view, side view, if we can take pictures from all sides of the face, it will be increase the accuracy of the model. The only problem is we don't have that much data in our center, especially online. Since we went online to download data, there's not much data on the lateral view. That's why we didn't include that in our study.
Thank you. Okay, there's another question from Dr. Junior too. He says that it seems like data that are not standardized is helpful in improving the AI training. If so, wouldn't images that you obtained from the internet serve this purpose better than images that you obtained from your own center? Thank you.
Yes, that's absolutely correct. So I think the images we obtained from the internet are probably more important than the ones we have from our center. The only issue is for that particular study, because we wanted images from top of the head and frontal face or face images, is that the internet usually doesn't give you data for the same patients from the top and front. And only this data can be found in our center. So when we did the training, we trained the models from the internet from separate images, either the top or the front. But when we tested, we had to test the data from our center because we need to have the front and top images of the same patient, which we can't find from the internet.
Okay, thank you. May I ask a question? I personally feel very interested about, you say there's supervised and unsupervised two-way to train the model. And I just feel curious about that. Is there any differences between these two methods in terms of their accuracy or their training efficiency? Do you find out any differences or what kinds of methods that you recommend? Thank you.
No, the only reason you would use supervised or unsupervised, it's based on the problem you want to answer, right? So, for example, in the metopic craniosynostosis versus ridge, there was no gold standard, so it was hard to find labeled data from the surgeons as this is normal or abnormal. So that's why using unsupervised was very helpful in that case, right? Because we don't need the surgeons to label the data for us. But when you try to do something more like looking at all craniosynostosis, it will be very difficult for the computer to figure all of this out on its own. So giving it some sort of help with data labeling, that will be useful. So for example, we worked on cancer studies. There's no way computer can identify cancer on its own. So we needed labeled data to tell the computer that's cancer and that's normal tissue. That's much more difficult.
Okay, thank you. So you think that for the photos of craniosynostosis, it had better to use unsupervised, but what if some like CT images? Do you think that it is also more useful to use the unsupervised, or we should use the supervised, like labeling?
For me, I think if we are able to label the data, then it's probably better to use supervised because it will be more accurate to tell the computer what exactly you're looking for, right? But if labeling is an issue, then probably unsupervised is the way to go.
Okay.
So I guess it depends if you are able to provide the labeling.
Okay. So do you find
Rami,
that?
Can I say something? Rami, can you
sure.
hear me?
Yes.
I guess I didn't ask question minutes ago. I think it's a connection problem. Just want to say hello to you, and then please say hi to Dr. Alice Ken.
I will do. Thank you so much.
Thank you.
Yeah, we have one more question. We have one more question from Dr. Andreas.
Andrea?
Monica, yeah.
Okay. Okay, it's very nice presentations. Might AI be useful to distinguish between positional plagiocephaly and craniosynostosis for laypersons? Any experience in that direction? Thank you.
I'm not sure if anybody tried to do plagiocephaly versus craniosynostosis, but I know there is a company that now has FDA approval to diagnose plagiocephaly alone using machine learning. I'm not aware of any studies to look at plagiocephaly or craniosynostosis, but I think it shouldn't be that difficult unless we're looking at lambdoid and plagio, because these are very close to each other. But you know, like identifying plagio versus metopic or sagittal might be easy.
Okay, thank you. Is there any questions from the audience?
Okay, may I have one question for Professor Hallac? Yes. Thank you, Professor Hallac's presentation tonight. Based on your presentation, some image acquisition you already have in your database. For example, you have 2D or you have 3D photographs. So could you give us a very briefly to differentiate what is the pros and cons once you have a 2D photo and a 3D photo to do the artificial intelligence? Thank you.
So again, like 3D would have more data. So if you use 3D images, you will be able to get more features to train a computer. For now, like let's say we want to do the sagittal, we have to take two pictures, one from the front of the face and one from the top of the face. The only problem with using 3D data, at least in our center, we don't have the computer capacity. So to teach the computer with 3D data, you need a lot of powerful computers. We don't have that in our center yet. But if you do, and you have the capacity to train the computer with 3D photographs, it's much easier. But one limitation you might need to think of is not everybody has a 3D system, especially if you want to make this available to the patients.
Okay, thank you, Professor Hallac.
Thank you.
Thank you. Any question from the audience? Any other questions?
Okay. If there is no more questions, I think it's now the happy hour. Okay. I would like to. Okay. I would like all of our audience and all our participants tonight with us in front of your screen. Please turn on your screen and to show your beautiful smile with Professor Rami Hallac together, and we will have a group photos. Yeah, and we can see our Professor Fayaz and Dr. Clement Ling, Dr. Natalia Jin Chen, and Dr. Wang Yuzhi. Thank you for your participation tonight. And I think now it's a very early morning in Dallas, right? Yes. Yes. So I will count to 3, and please give me a happy or lucky gesture, like a heart or a thumb, anything you can post. Okay, 1, 2, cheese. Okay, let's turn to the next page. Okay, once again, 1, 2, 3. Okay, thank you very much. Thank you very much. Okay, Monica, do you have any closing remark to let us know, or could you give me anything of your feeling to be as a moderator for tonight's ICC?
Well, I personally feel very lucky to join the ICC and as the moderator of this fantastic talk. And I'm quite interested in the AI machine learning, and I feel like AI could help us in many ways in the craniofacial field, like not only the craniosynostosis, not only the congenital problem, but also for some trauma. Then we should start some applications in that. And I hope that we will have chance to have cooperations with Dr. Rami, and I personally, if there's any chance, I would like to visit the Dallas. And Professor Howard Chang, would you like to give us some encourage or please have close remark?
Thank you. Actually, I enjoyed the talk from Dr. Rami tonight very much, and also learned a lot. Although I'm the panelist tonight, but actually still have a lot to learn. I think AI, although still has some limitation, but I think with more and more knowledge and technology, everything development, I think maybe someday in the future, we can use the AI for the system for craniofacial surgery. Thank you very much.
Thank you, Professor Howard Chan.
Okay, so yeah, please go ahead.
Please.
So finally, at last, I would like to pay my great gratitude to Professor Rami Hallac. Actually, Hallac's always taking care of me when I was in Dallas in his lab, M Center, Analytical Imaging and Modeling Center, and be hosted by Professor Alice Ken. So I learned a lot of image analysis experience from him as well. So thanks again, Professor Hallac, and thank you for all our both very professional panelists, Professor Xiu Ling and Professor Howard Chen. Thank you for your participation, and thank you, Fayaz, and thank you, Professor Clementine as well. Especially thank you for Professor Low. Okay, our next ICC presentation and webinar will be hosted on the July 3rd. And our speaker is the Professor Kyotoku. I think that everybody knows Professor Kyotoku. He had ever been our fellow in the Chang Memorial Hospital Craniofacial Center as well. So 3 weeks later, we will have another very nice and very good presentation. So thank you, and have a good day and have a good night, and see you next time. Bye-bye. Thank you, Rami.
Thank you. See you next time. Bye.
See you. Bye-bye. Thank you, Dr. Joe. Thank you.
Thank you. Thank you. Thank you. Thank you, Dr. Fayaz. Thank you, Dr. Werner. Thank you, Dr. Natali.